Welcome to the first FPA podcast in a series where we unpack what every surgeon should know about their billing and coding teams to understand if they're being appropriately paid for the care they deliver. I'm your host, Marney Reid, and I'm joined by two incredible guests. We have Alexandra Stephens from Fellow Health Partners, an expert in revenue cycle operations, payer policy, denials, and proper documentation. Hey, Lex.
Hi, Marney. Hi, everyone. Thanks for having me.
And Dr. Abigail Campbell, a sports medicine surgeon at NYU Langone. Abigail, thank you for joining us.
Happy to be here.
Lex, let's start with some key RCM terms that surgeons should really know, like clean claim rate, first pass resolution, and denial categories. Can you break these down for us?
Absolutely. These will tell you almost everything you need to know about your revenue cycle and how it's performing. Let's start with clean claim rate because that's really your foundation. Clean claim rate is the percentage of claims that go out correctly and get processed and paid by the insurance company with zero interaction. No edits, no denials, no follow up. It goes straight through. You want this number at about 95% or higher. If it's not, something is breaking down before the claim even gets to the payer. And this is important. Clean claim rate is not really about the surgeon, it's about your front end and coding accuracy. What drives a strong clean claim rate is correct patient demographics and insurance information, proper eligibility verification, proper claim coding with valid current diagnosis and CPT codes, and especially proper claim submission channels for each payer. One thing we often see is split plans, where coverage changes based on the procedure or the place of service. If that's not verified correctly up front, the claim will be denied no matter what because it's submitted to the wrong payer.
Yikes. Okay, could you give us an example of that?
Of course, let's use an example from New York. Emblem Health, a lot of their plans operate as split plans. For facility billing like an ASC or a hospital, the claim has to go through Blue Cross. But for the professional side, it goes to Emblem. So now you've got the same patient, the same procedure, but two completely different payer paths depending on what's being billed. And here's the key. This isn't a billing issue. This starts at the front desk. The type of provider and the type of procedure determine where the claim needs to go. If your front desk office team doesn't understand how that plan is structured, the claim is wrong before it even leaves the building. Now let's talk about another payer that loves to make the submission process, I guess you can call interesting. Blue Cross Blue Shield. They're a massive player. On the surface, it feels like it should be simple. It's Blue Cross. But once you go to submit a claim, that's when things get layered. You've got out of state plans, local plans, federal plans, self funded groups, all sitting under the same Blue Cross Blue Shield umbrella. Then you start factoring in where the service was rendered, what type of plan the patient has, and suddenly your biller needs to know whether to submit to the local plan, to the member's home plan, or figure out which self funded group to submit to, which is a completely different route. And it doesn't stop there. You've got variations like Blue Cross Blue Shield of Illinois, Florida Blue. The list just keeps going. While it all technically falls under Blue Cross Blue Shield, the reality is it's not one playbook. It's a maze, and it's up to your front desk and billing team to set up correct payer submission paths. They also need to be aware of the new plans that come up or plan changes that will ultimately affect where you route claims for a submission. Given how complex the payer landscape has become, this work is both time intensive and increasingly difficult for in office teams to manage. Most groups we see are already operating at full capacity. So, layering on the nuanced, fast changing requirements we just discussed becomes nearly impossible. That's a major reason why many medical groups and ASCs turn to outside RCM partners, not because their teams aren't capable, but because the bandwidth and ongoing training required to stay ahead of these changes simply isn't realistic for an already overextended staff. The real takeaway is this: many denials happen because the claim was routed incorrectly. Wrong payer, wrong portal, wrong plan. It's avoidable, but only if the routing is right from the start. What should be as simple as question as where do I submit the claim? ends up being one of the biggest silent drivers of delays in your revenue cycle. When that answer isn't clear, everything downstream slows down. That's exactly where claim scrubbing tools play a big role as long as they're set up correctly.
That's incredible. I've been in healthcare for almost 19 years, and just hearing how convoluted this process is, and these poor clinicians are just trying to deliver extraordinary care to their patients. The office staff is trying to keep up with AI and just how impatient and quick and quite frankly all of, the researching patients out there that come in feeling like they know exactly what kind of care they need. Just incredible, Lex. So how often do these types of processes get changed, and what kind of notification goes out to the medical group and, to the point you just made, to that front desk person or ASC?
Honestly, it's periodic, and that's exactly the problem for most in-house teams. Here's another New York-based example. Emblem Health rolled out a new plan as of January 1st called NYCE. It's another surprise split plan, but this time it's between Emblem and United. And here's the reality. Providers are still trying to figure out where claims are supposed to go and what fee schedule even applies. What makes it even more frustrating is that you can call the payer twice and get two completely different answers depending on who you speak to. That's why having a direct provider rep matters. But even more than that, you need a front office team that's actively paying attention in real time because it's not just about getting notified, it's about catching changes early and adjusting before it hits your revenue.
So I'd like to bring in Dr. Campbell here real quick. You've been in practice for 5 years. You most likely work at a couple of different clinics. Looking back to your front desk team, how much time do you feel like they really get to research these new plans that come out in these new policies?
Minimal, because they're already overextended. And a lot of these people working at the desks don't have medical background, right? A lot of them came from other jobs where they were doing clerk type of work. My secretary was a barista at Starbucks before she started. So it's not like they fully understand the medical side of things nor the insurance process. Their job is to basically check a box, check the patient's insurance plan, but they don't understand the nuances nor have the time and bandwidth to figure out if something's changed or not. They just get a denial or an approval.
Wow, I am going to guess that a large reason why medical groups and health systems want to keep their revenue cycle in-house is because they want to keep everything inside and control it. And I totally understand that concept. But if I'm personally managing a medical practice, I think I'd want my front desk team really focused on patients, moving the check-in and check-out process as smoothly as possible so they get a great experience and so my clinicians have a smooth flow as well. Lex, let's put some numbers to this. Let's say a medical group bills around 40 million a month. Remember, bills, not necessarily collects, but bills around 40 million a month. What does the potential revenue loss look like if the front office team is not up to date on new plans like you just mentioned, or plan policy changes and claims are wrong before they even leave the building?
Ugh, that's a great question. Okay, let's say your group bills around 40 million a month and 20% of your payer mix is from a payer that requires claims to be billed to a different entity. That is that split plan I was referring to earlier. That's 8 million in charges tied to one payer. If your front office doesn't understand exactly how those plans route, you're potentially sending a huge portion of that down the wrong path. Now, obviously, charges aren't collections, but even conservatively, you're looking at roughly around 400 to 800,000 in at-risk revenue tied to preventable denials. So the real question becomes, how often is your front end team staying ahead of these changes? If you're a surgeon out there or a practice admin, sit back and ask yourself these questions about your front office team. Have we given them the support and time to seek continuous training? Have we given them the resources to get the training they need? Or even do they know where to look for this training? Because if
That,
not, it's just not an operational issue, it's a revenue problem.
that's wild. So say a surgeon notices this or is curious and asks the in-house team some more information on how they process these and if something can be fixed that was denied? How long is that going to take? What does that mean for them in their process? And how long could it take to recoup that money?
The actual fix is usually quick. Resubmitting the claim correctly or updating the clearinghouse setup isn't a heavy lift. The real issue is what happens after that. Once you push the claim back to the payer for correct processing, that's where things get messy. We see cases where the payer doesn't even acknowledge the corrected claim or denies it as a duplicate, which means it needs another touch. So, what should have been a simple correction turns into multiple follow ups and delays, and that's what really starts to impact your cash flow. At the end of the day, a true clean claim means zero touches. When your front end is tight and your team stays aligned with payer requirements and updates in real time, claims move quickly and cash just flows.
So if I were a practice admin out there and I'm listening to this, my first thought would probably be, how can I make sure that I give my front desk team time to, get educated on this? Or I'd want to know that if I'm bringing a company in, that they have time to come in and they're willing to take time to train my front desk team on any policy that they hear about that's coming in. So great information, Lex. Can you now talk about the term first pass resolution and what does good look like for a first pass resolution rate?
First pass resolution is exactly as it sounds. These claims that were denied at first, but are resolved with one follow up. Having an initial denial isn't rare, and surgeons should know that not all denials are avoidable. So don't be hard on your RCM team if you have some. On average, payers deny roughly around 10 to 15% of claims. And a portion of those denials are from bundling denials, authorization clarifications, and medical necessity.
That's really helpful to know. So what happens next? Say 10 to 15% of the department's claims are denied. How can we make sure that we are getting paid for those, if at all?
Well, that's a great question. This is where a medical group has to truly decide whether they're prepared to defend the claim immediately. In the ideal scenario, everything is documented correctly. Your team knows exactly what needs to be submitted to the carrier, and the authorization matches. The diagnosis, the CPT code, place of service, everything's in place. Those are the claims that don't sit in the AR. They get resolved quickly, and as long as your billing team stays on top of the insurance carrier to make sure the corrected claim is received and pushed through properly for processing. But if those pieces aren't aligned, that's when one denial turns into multiple touches, delays, and rework. Anything beyond that is where you start seeing delays, increased costs, and cash flow issues. This brings us to the third and equally important metric, denial categories. Denial categories are the reasons insurance companies give you for not paying your claim. But more importantly, they're how you identify patterns in your denials.
So, how could a practice identify these patterns and who's responsible for looking for them?
To properly identify these patterns, they should really be looking at what procedures are constantly or inconsistently being bundled, which claims are denied for medical necessity, and what documentation is required to support it. Which codes require additional procedures or add on codes to be billed correctly? Which claims are denied for frequency? And what are those limits? And once you understand those patterns, you can stop reacting to the denials and start preventing them.
I have to imagine that Dr. Campbell, who is, an orthopedic surgeon, so ready to get in there and fix it, is listening to this and going, okay, what can I do? I need to do something. So, Lex, can you go a little more into detail about how a billing team can be preventing these issues instead of reacting to them, and maybe even share an example of something like a recurring denial, or you were talking about unspecified diagnosis codes, or even something I heard called local coverage determination diagnosis requirements, which is a mouthful, but could you kind of walk through what that looks like?
Absolutely. This is where things really start to separate reactive teams from high performing ones. The biggest shift is moving from fixing denials to preventing them before the claim ever goes out the door. And that really starts upstream, meaning with your coders and where the process starts, your front desk, not in the billing itself. Instead of waiting for a denial to come back and then figuring out what went wrong, Strong teams are building payer rules directly into their workflows. That means front desk, clinical staff, coders, and your billing team are all aligned on what each payer requires. Taking something like unspecified diagnosis codes or local coverage determination requirements, otherwise known as LCD. These are some of the most common and most preventable denials we see. If a provider documents knee pain but doesn't specify laterality or severity, or doesn't tie the diagnosis to medical necessity for the procedure, the claim might still go out clean, but it's almost guaranteed to come back denied. Now, a reactive team waits for that denial, reworks the denial, resubmits the denial, and now you've added 30 to 60 days to your cash cycle. A proactive team never lets that happen. They're using things like diagnosis checklists tied to specific procedures, payer specific medical necessity guidelines, and simple prompts in the workflow that, let's say, if you're billing this CPT and this diagnosis is required to be supported in the documentation. Now, I want to make one thing clear because this is important on a compliance standpoint. This is not about choosing a diagnosis code just to get a claim paid. It's about making sure the documentation supports the service being performed and educating the providers and the coders on what each payer requires. This way you can meet those guidelines before moving forward with the procedure. So through ongoing feedback, audits, and education, you're helping providers understand what needs to be documented before the service is even performed. And you're helping your coding and AR team avoid preventable mistakes on the back end, because that's the real goal. You're not gaming the system. You're making sure all the boxes are checked up front so you're not performing services that aren't supported and you're not losing revenue later on something that could have been done right the first time. And when you get that alignment right, your clean claim rate goes up, your denials go down, and your cash moves a whole lot faster. Let me ask everyone listening, if you have an in-house team, does that team truly have the leadership support, time, and resources to move from being reactive to becoming a high-performing team? And when I say reactive, I don't mean your team is sitting around waiting for denials. Reactive means that they're so overloaded, they don't even see the new plans, the new policies, the new payer rules, the reoccurring denials. They're already underwater before the change hits. In most groups I audit, teams have been in reactive mode for so long, they don't even realize it. They're working hard, that's not the issue. But hard work without the right infrastructure doesn't fix the denials, it just sustains them. And every audit confirms the gap isn't the effort, it's the execution.
This has been so helpful. I learned so many good terminologies. I learned what all of these things mean that we definitely don't learn in med school and residency. And I feel like all surgeons should be taking a closer look at how this is all done in their own system.
Couldn't agree more. This is such a complex topic, and I really appreciate Lex spending the time to break it down and make it a little bit more easy to understand for those of us who may be learning about this for the first time. Dr. Campbell, always so great to have you join us. As we said at the beginning, this is a series of podcasts. The next one will talk about key metrics and reports that every physician or office admin should be looking at and should get provided to them, whether it's from their in-house team or from a third party if they outsource their RCM. If you'd like to get a free consultation from Lex with fellow health partners just to see how your RCM is performing, please email info@fellowhealthpartners.com. See you on the next one. This podcast is for educational and informational purposes only. The views and opinions expressed in this episode belong to the individual speakers and do not represent formal medical or billing advice. The Foundation for Physician Advancement and fellow health partners make no guarantees regarding outcomes, reimbursement, or financial performance, and we are not responsible for any decisions made based on the information discussed today.